And welcome to the Research Works podcast, brought to you in association with Curtin University and the Healthy Strides Foundation. Your hosts are Dr. Dana Poole and Dr. Ashley Thornton, and together we will interview world-leading researchers in the area of child health to support your practice in being more evidence-based.
Welcome back, everyone, to another episode of Research Works.
Yes, welcome back.
We are so excited to be delving into the world of occupational therapy today. And we have the most trustworthy of tour guides, Dr. Simon Garbellini from Kids Rehab WA at Perth Children's Hospital. The article we're talking about with Simon was published in the Journal of Hand Therapy in 2021 and is titled The Neurological Hand Deformity Classification, Construct Validity, Test-retest and Inter-rater Reliability. Welcome, Simon.
Hello, everybody. It's nice to be here.
Oh, we are so excited to have you here today, aren't we, Dana?
Yeah, we are. We've worked together for so long and I haven't seen you for so long. And it's just nice to be in the same room together again.
It sure is. It's been a really long time. I only saw Ash the other day. So.
Well, like we said, Simon, we're so happy you can join us today because I think, you know, both of us have been cheering on from the sidelines as you went on this massive PhD journey. And we're excited that you can talk to us about a bit of this work today.
Yes.
So for our listeners, let's tell you a little bit about Simon, who is a senior occupational therapist and has been part of the cerebral palsy mobility service at Perth Children's Hospital for more than 15 years now. Simon completed his PhD in 2020, in which he focused on the use of upper limb orthoses to manage hand deformity in children with cerebral palsy, and developed the Neurological Hand Deformity Classification, a tool to help clinicians improve treatment and reduce pain for their patients. Simon has been one of the site leads here in Western Australia for several multi-site randomised controlled trials of upper limb orthoses for children with cerebral palsy. And in addition to his clinical role, Simon also works as the research coordinator for Kids Rehab WA and the School of Allied Health at Curtin University.
Flippin' heck. That's impressive, Simon.
It's just a lot of words, really.
That's not true. Simon is one of the hardest working people I know.
Indeed,
That's very kind.
Yeah.
I know. I think what I find really, really cool is that I know we've all been through our PhD journeys now and all around the same-ish kind of times, and we've all come out the other side, but it was kind of cool to see the thought of, you know, when you wanted to do the PhD at first and bring it all together, and it's just really cool that we're here and we can talk about it now.
Yeah, and a long time too, because working clinically and doing it part-time.
Yes.
Yeah.
It's many years.
Yes, it is.
It is, but
no,
you've shown us
really
that
worthwhile.
it can be done.
Yeah,
and done well.
Absolutely.
Thank you.
So, Simon, we like to start our episodes with a bit of an icebreaker question.
Yes.
Okay.
And today's question is, what was the first thing that was on your mind this morning?
First thing this morning was, why is my dog barking at 5:45? And there are a couple of other things as well. The other one is, I really need to get a new clock radio because my clock radio comes on and it's just static. So it's not a very nice way to wake up. And then the third thing is, you know, you guys know what it's like. And hopefully I actually sound like I know what I'm talking about.
Story of my life.
Join the club. No. Oh, good.
What about you, Dana?
Oh, see, I woke up this morning because it's getting quite dark now. It's no longer summer. So I debated with myself for about 30 minutes on whether I should go for a run, go for a walk. Should I do some exercise? Should I do some strength training inside? And because it took me so long to make any decision, I didn't end up doing anything at all. So I had to come to work.
They say it's the thought that counts though, right?
They do say that, indeed. The follow-through was really not seen today, but the first thing and a big debate. So, yeah, that was my thought. What about you, Ash?
Well, my morning started a little earlier than it should have. I had one of my children, who shall not be named, decided to wake up at 3 a.m. this morning. So my first thought was, I hope this is very quick so that I can go back to sleep for a couple of hours before I actually have to get up again. But then the second thought I had was a really happy one because I got a notification that I'd received a refund that I've been waiting for 2 years.
That's fantastic.
Yeah.
Tell us about
from,
it. What's it from?
Also unnamed airline for some flights that were cancelled during the height of our COVID pandemic back in 2020.
Oh my gosh.
Yep. It's been a 2-year journey. So that kind of, I felt like I was at both ends of the happiness spectrum this morning.
That's great. Yeah. You've got all this money to spend now. Time for looking at a holiday.
Don't tell my husband. No.
Yes, hope he's not listening. Oh, that's a good morning thought.
Yeah. Well, now that we've got that out of the way, Dana, why don't you give us an overview of the paper?
Oh, my pleasure. All right. So in terms of a background, this is a measurement study designed to examine aspects of the validity and reliability of the Neurological Hand Deformity Classification, which is an impairment-based tool that classifies hand deformity into one of two ordinal scales, that being flexion or extension deformities. So the data was from a convenient sample of 127 children with cerebral palsy, 66 males, 61 females, ranging in age from 8 months to 15 years across all manual ability classification systems, or MAX levels, 1 to 5, and these were then analysed. The construct validity was assessed by testing predetermined hypotheses of relationships between neurological hand deformity classification and measures of body structure and function and activity measures, with observed performance using the chi-squared test of independence and Spearman's correlation coefficient. Test-retest and inter-rater reliability were assessed by calculating agreement between repeated measures and paired raters using weighted kappa and Cohen's kappa with 95% confidence intervals. So with the results, the predicted hypotheses for the neurological hand deformity classification were met in 9 of 10 Spearman's row correlations with body structure measures and in 2 of 7 correlations with activity measures. So the expected relationships between the neurological hand deformity classification and other measures, stability between repeated measures and acceptable between rater agreement supports the confidence in classifying hand deformity in children with cerebral palsy with this particular classification tool.
Thanks, Dana.
Thank you.
So, Simon, I was hoping we could kind of take a bit of a zoom out from that abstract and that you could start by giving us a bit of an overview about hand deformity in children with cerebral palsy. Why does it happen and why is it important that we intervene when it starts to happen?
Yep, which is a really good start. We know that more than half the kids that have cerebral palsy have problems with their hands or have some upper limb involvement. So it's a lot. And that the severity of the deformity can start at a really, really early age and can really limit how much the kids can actually use their hands in everyday activities.
Yeah.
So we know that with cerebral palsy, the damage to the brain is static, so that it doesn't change, but it causes all of those positive and negative symptoms that arise. So the positive symptoms like spasticity or increased muscle tension, the negative symptoms of weakness. So we know that there's a really imbalance there. And if we don't look at how the kids are presenting, we don't know how to actually intervene for them. But if we let things go and as the kids grow and get older, there's potential with the weakness and imbalance and extra muscle tension in opposing muscle groups that the hand deformity will actually get worse.
Yeah. Yeah. No, that's really important. And I think when we talk about, in terms of just, I guess, classification systems and why we use them, I suppose, I think we're all really quite familiar now, which is actually a really good thing. We talk about GMFCS levels, we talk about MAX, but now we're using these classification tools. Can you sort of maybe just explain to some of our listeners why classification tools are actually so important when we consider these things?
So they're really important so that we can actually talk to each other. Especially from a clinical and a research perspective. And so that we're talking about the same thing.
That's right. Yeah.
So the gross motor function classification scales kind of changed everything for us in the way that we talk about kids' general mobility.
Yeah.
And if you start talking about GMSS level 1, now you've got a picture in your mind of actually what the child presents like.
Yeah.
And then later on, the development of the manual ability classification system was to look at how kids use their hands in everyday activities or how they handle everyday objects.
Yeah.
So the classifications are really important just to give a picture of the child. So no matter where you are, whichever country you're in or whichever facility you work at, you're kind of talking about the same thing.
Yeah.
So the classifications are really important as just, they're not assessments. They just kind of tell you what the child presents like. So that then you can go, I've got a really good picture. What is the next step that I need to take? What assessments do I need to do? Or how do I talk to the families about what's going on with their individual child or the children themselves if they're old enough and they understand.
Yeah. It's such a useful communication tool, isn't it? Like I remember, I think, it's been about 20 years now, I suppose. I remember when I was first studying, it was kind of like mild cerebral palsy. That's how we would describe it. And like, doesn't tell you anything. It doesn't tell you anything about any other part of their body or, and I think, were we describing gross motor? Were we describing hand position? Like there was no clarity about it, was there?
No, not at all. You could have kids who couldn't walk but could use their hands well.
That's right.
So is that moderate?
Yeah.
Because it's kind of in the middle there somewhere.
Yeah.
Or you can have a child who presents with one limb involved.
Yep.
So their hand, one arm.
Yep.
And it can be really severe. They can have no active movement.
Yep.
But they can still functionally do everything for themselves because they manage one-handed or with adaptations.
Right. Yeah.
So it just adds a lot of clarity to what you're actually talking about.
Yeah. And I love your point about it being, these classification systems being methods of communication, because often these children, they see multidisciplinary teams, but then potentially lots of different teams for all of their therapeutic and clinical needs. So to have almost, for want of a better term, like a universal language that you can all speak to each other to help describe these children and their strengths and challenges is, I think, really beneficial.
I think absolutely. And so I guess maybe now that we sort of talked a little bit about classifications and more, I guess, in terms of detail about what we tend to see in the hand in children with cerebral palsy, which is where this sort of classification tool sort of came about.
Yeah.
Now, we're all very handsy people, and this is an audio podcast. You can't see our hands, but you can see we're all about to sort of demonstrate what flexion and extension is as we talk through the ranges. But
constantly.
It is. I'm going to have to just maybe sit in my hands soon. But I guess maybe just going through about, you talked broadly about the imbalances that you get from positive and negative signs. What are some of the things, I guess, just to describe in more detail now, particularly for the OT listeners out there, what have we seen in the hand? What are some of the typical postures and I guess how that relates to the classification tool?
Yeah. If you go back to the 70s, there was the Zancoli classification that was developed, and Zancoli were surgeons, and they really only looked at spastic hemiparesis.
Yeah.
And flexion, so that the direction of your wrist and fingers going down.
Right.
But we know, and from experience, is that children can present with their wrist either going into a flexion position or into an extension position.
Yes.
So there is, even though the extension positions are much less of a percentage of the children that present, it's, your wrist can go in two directions.
That's right.
So your deformity can happen in two different ways.
Yeah.
Which then kind of gives you a clue as to which muscles are overworking and which muscle groups are more switched on that are then causing the dynamic deformity.
Yeah, sure.
So the classification was really developed to look at the balance of how the wrist and finger muscles move together.
Yeah.
And in the introduction you talk about the two ordinal scales. I had to do that from a statistical analysis perspective.
Yes.
But really it's just one scale.
Yeah.
That kind of starts, your reference point is a neutral wrist.
Sure. Yeah.
And then you're just looking at how much active wrist and finger movement the children have.
Yep.
And what position the wrist is going into and how much movement they've got relative to the position of the wrist.
Yeah.
Yeah.
And I think that's really lovely because you are not just talking about just the wrist. I mean, we know that the hand functions with a combination of movements, right? And that's the beauty of the hand. You've got stability and mobility all at the same time.
Yeah.
But it's, I love how you did actually put the ordinal scales to it because it kind of just helps you to picture, I guess, what it looks like, in your head if you want to start looking at numbers and kind of understanding them and there's positions and extension, what the fingers might be doing, what the thumb might be doing. Is that sort of broadly, I guess, what the tool actually looks at?
Yeah, it does. So the balance of how the wrist and finger muscles work is because the finger flexors cross the level of the wrist, your finger flexors have a really big impact on what position your wrist goes into when you're opening and closing your fingers.
Yeah, that's right.
So it's approaching it from that aspect. Each level kind of adds a layer of, if you go a little bit into extension or a little bit into flexion, these are kind of the muscles that are going to be overworking.
Yeah.
And then if you go to the next, so if you go from an F1 to an F2, then you know that an F2, the finger flexors are more involved. So it kind of, as you start from that zero neutral position, you add layers and add more complexity of the muscles that are actually having an effect on the position that your wrist and fingers is going into.
Yeah, sure. I love that.
Yeah.
Yeah.
So could you talk us through the process of classifying a hand or wrist deformity? So a child comes in and sees you clinically. What's kind of the process that you go through with the classification system?
Yeah. So the classification system was developed by a fantastic hand therapist called Judith Wilton, who is a great friend and mentor of mine.
Yeah.
And she really established hand therapy in WA. She found from her years of practice that the kids' patterns of movement were kind of similar when they were coming in, and that you could actually classify it, and based the classification system on the Zancoli classification in part.
Yep.
And so having the opportunity to work closely with her, I was able to then work with her to develop the classification. Is in, I can't even remember the year now, we had an honours student that came through Curtin and we looked at the reliability of the classification, but there wasn't any guidelines on how to use it. So roundabout, sorry, Ash, to come to your question is that we developed a manual and a website which actually goes through how to set up, how to administer, how to score, the difference between the levels, and how those levels might match to some of the interventions that you might actually use. So if a child comes in and I want to know what their classification is, I'll sit them down. I'll get an object roughly about the size of their fist, and I'll put it on the table in front of them, about a forearm's distance away, and just ask them to try and pick it up and put it down. And then you're observing the way that the wrist and finger muscles move together and the position of the thumb, and then you're just following the little classification guide to see. So the more with the wrist flexors, and you're going by the maximal amount of wrist flexion to classify them. That is how they then either get an F1, 2, 3, 4. If they remain in extension, then they're an E1 or an E2. And the further away you get from that zero, so your E2 and F5, the less active movement you've got.
Right. I love that. I really and I like how simple it is. You don't need fancy tools for it. It just means you can do it within a clinical setting. You might need some training to understand what those levels all mean, but you've made it very practical with a lot of accessibility.
You do have to familiarise yourself with it. I don't think there's any special training. The more you look at it, and it's really well outlined on the website too, and there are video examples of each of the levels. And then it's talking to people and kind of going, oh, if you have a look at this, what do you think? This is what I think.
Yeah, sure.
And I wouldn't get too caught up in being so specific, but it just gives you that general view of, okay, this is what the balance of the movement is like.
Yeah.
If I know that a child's wrist is going into lots of flexion, then I know that I'm going to want to test their wrist flexors and to see how much passive wrist extension they've got.
Yep.
To see whether those secondary changes in the muscle and the skeletal system, how much they're having an impact on how the kids are moving.
That's great. And it's almost like I guess the way you describe it, in my head, I always think of like a decision-making tree. You're going through one thing and, because otherwise you can be quite overwhelmed with what you see sometimes and what might be affecting what. But this gives you, a bit of a guidance of what it is you might need to look at. So I guess in terms of that, before we get into too much of the results here, because I think you'll contextualize it a bit, is how does that sort of classification tool shape how you decide what interventions that you could therefore use?
So it's a good question.
It's a big question.
If you actually see me, you would see this look of horror on my face and sort of smoke coming out of my ears with the poor little man trying to start a fire in my brain. When I start looking at the classification and how the kids are moving, then the assessments that I want to do are your passive ranges, how much active range the kids have, whether they can grasp and release an object.
Yeah.
The more severe the deformity, the more difficulty the child's actually going to have.
Yeah, sure.
So there are other assessments that you can then use that follow on from that. So your goniometry, or you might do a box and blocks or a Melbourne assessment.
Yep.
To really clarify what you're actually seeing and make sure that the structures that you think are involved.
Yeah, sure.
But it's really impairment-based.
Yeah, yep.
So you're looking at those impairment structures, but then you're almost trying to go, well, how does that affect activity from there? And does that stop the child from being able to participate in what they want to be able to do?
Yeah.
So it depends on what you've got available with the other assessments that you've got. You know, you can do manual dexterity and box and blocks and the nine-hole peak test, and they're all time tests to see how fast you can go, but it's really unilateral.
Yeah, sure.
And the classification is impairment-based unilateral.
Yeah.
So you're just looking at the affected limb.
Yeah.
Whereas you really have to take that next step and then put it into context of, well, then how does that affect how they use two hands together?
Yeah.
So that might be, you might do some more activity assessments like a assisting hand assessment or a two-handed assessment to try and put it into more context of what you actually want to look at.
Yep.
Yeah.
If I find that the children have more severe ratings, so F3, 4, 5, and I know that I've done my goniometry and I know that they've lost passive range, then that might help me to guide what kind of upper limb orthosis I might use in that particular case, and when and where. Am I going to be using something for function to try and position the wrist or thumb in a better position so that they can perform an activity that they want to perform? I'm not saying put an orthosis on and just leave it on and expect them to be able to do miraculous things. You really need to be targeted with what you're doing. Or do I need to do something at night where they get a long low duration stretch that are going to help to stretch those muscles and mobilise those tissues so that when they go to use it the next day, there's enough available contractile length for them to be able to bend their fingers to hold something or to stabilise it with grip.
Yeah. And I love that, you know, obviously, like you said, the classification is looking at the impairment, but what you're saying is from an intervention perspective, making sure that you are kind of extending that to activities and then from that, you know, what's meaningful for the child and what activities do they actually want to participate in, and making sure that what you're doing is targeting those things. That's the most important thing, isn't it?
Yeah, absolutely. We I think we can get caught up in the impairment side of things and how we actually treat it and lose some of that context, and we can get stuck in focusing on one area and one set of assessments rather than being across that broad range of,
that's right.
Okay, well, we've got the impairment. So how does that affect their activity and what they want to do?
It's just building that clinical picture, isn't it? It's not just one. You can't, which is why they're so clear about, you know, these classification tools. They're not for assessment necessarily. They're to guide. They're to give a picture. They're then to sort of funnel your focus into a particular area then. And I think what you said there is so great, Simon, that we know that this tool is really impairment-based. I mean, it's very clear. It's body structure and functions to understand what's happening there, and therefore how do you look at it in the broader context of their goals? Because their goals, like you said, might be that we need to have a longer low. So it might be a nighttime splinting, like you said. But in other instances, it might be more active. And, you know, there's just, I love that sort of stuff. It's great.
And if you've got a concept of how much active movement they've got, even if they go into a deforming position, if it's not functionally limiting,
that's right,
then you might not choose to do something. And the more active movement the kids have got, the more low profile and the more dynamic the material you can use.
Wonderful. So
then you come into all of the dynamic lycra or neoprene or, you know, your dynamic taping. It's kind of those links and considerations. So I think the more movement you've got, the less I would do, and the less movement you've got, the more I would do, but I'd probably do it at night to maintain good structural length and position.
I love that. And I love that, you know, coming back to the classification system, you've manualized it. It's a website. You know, this is such an amazing knowledge translation tool for all those clinicians who might be listening and want to utilize, you know, all of those resources that you and your colleagues have made available. So I think that's, you know, that should be commended, because it's really, you know, an application of research, evidence and knowledge. So
absolutely. No, I absolutely love that.
The other thing too is that I believe in sharing information for the betterment of the people that we see and treat. So it's freely available.
Yeah, that's
online.
Really cool.
You don't need a subscription. You don't need to pay. It's just there. There's downloadable resources that you can
So great.
You can download to help you along the way. So there is a decision-making tree that kind of helps you work out what classification system, and there's very proud of it, and there's really good information there. And it wasn't just me; it was a group effort and
an amazing team,
some smart people helping me along.
Yeah, absolutely. All right, so shall we get into some of the methods and results from this paper, which people can understand and have an appreciation for all of the work that has gone into that website and resources when they go and access it. That you looked at construct validity as a start point, and when we talk about construct validity, we're describing the extent to which a measure kind of behaves in a way that's consistent with what we might think or hypothesize scientifically. And we often base that maybe on an existing theory or clinical reasoning.
Yeah.
So there's all these kind of ways that we arrive at that decision. Could you explain how you determined the construct validity of the classification system?
Yeah. So there's lots of different types of validity. So coming on the right validity or choosing the right validity to actually study was
a bit of a minefield.
It was a bit of a minefield. Good old Cosman framework. I really wanted to know whether the classification actually did what we thought it was going to do, and whether it measured and how we expected things to change, whether we could actually measure that well. And because there is no gold standard to actually measure it against, I can't compare and go, oh, look, there's a direct comparison.
Yeah.
So I had to pick the components of the study that I could actually compare it against. I know that sounds a little bit weird, but because my PhD was kind of nestled into bigger, larger randomised control trials looking at the use of rigid wrist and hand orthoses for kids with CP at different age groups, we were actually collecting lots of impairment data. So I had range of motion and manual ability classification. We had box and blocks. So I thought if I've got those, I can actually look at a correlation between those two items, which are either impairment-based, body structure and function-based, or activity-based, and then go, okay, if I get this score on an able hands kids or box and blocks, what would I expect the classification to kind of say? So that was the development of the hypotheses. Was if I could say this is what I think the classification is going to do and compare it to the results, then would my hypotheses be matched?
Yeah.
And so thankfully 9 out of 10 of the ones that I thought were going to match and showed that the classification behaved the way that I thought it was going to behave, whether it was kind of a negative correlation or positive correlation with those items, then established that, yes, if I'm actually going to get that I can measure that construct of hand deformity in a really real way.
Yeah.
Yeah, that's really cool. I love how you did that because you had these, it brings in your clinical reasoning, I guess, is the whole point, isn't it? Like you thought it through and it's like, does this actually make sense in the real world in terms of what I actually see?
Yeah, totally. If you have less active movement, then it would correlate more with the more severe end of the classification.
That's right.
Yeah.
And it makes sense. And that's a great way of looking at it. I love how you described that because I feel like validity, once people talk about all the different kinds of validity, your brain just goes, oh my gosh, like there's so much to think about. But right there, I think I kind of go, it makes sense. Is it measuring what I anticipate that it is measuring? Is this what it is?
And it wasn't just one comparison you were making. You made 9 comparisons for structure and function, and you made, I think, 7 for at an activity level, didn't you?
10 and 6.
10 and 6, sorry, See, there you go.
Don't quote me on that. It's been a while.
It's burnt into my brain.
It was 9 out of 10 hypotheses for body
That's right.
Yeah, which is pretty
structure.
Yes.
Cool. Yeah.
And it was kind of like that one that I missed out on. I was really dark on my I thought, I should have known.
But I love again that, this is the power of science, is that you then test out your hypotheses. And your clinical intuition said one thing and, there was this one where you went, oh, okay. And, you can be then directed by your data. Like it goes hand in hand, isn't it? It's not one or the other. They go together.
Yeah.
So the next one I want to talk about is the reliability side of things, because I know that you tested, test-retest reliability. And I feel like a lot of people kind of are more aware of what that is because they're taking rats. And they'll know if they're taking their rat, whether are you sure this is negative or is it really positive? And there is that, and then people then take multiple rats to see and to confirm. So I feel like reliability is something that we are kind of understanding a bit more, a bit different, I know, in this context.
I think it's a great analogy though, because then we're going to talk about inter-rater reliability as well.
Yes.
So if I do a rat and then you do a rat on me.
I feel like I don't need to answer the question.
Just related all to rats. But yeah, I guess the importance in this context of, I don't think so, importance of taking rats, but the importance of establishing reliability here is because it's not always going to be you that's going to be taking the measure.
No.
And, that's an important point, isn't it?
Yeah, that's right. So, validity was does the classification measure the construct of hand deformity?
That's right, yeah.
And then can it reliably be done, not just by me, but by anybody who comes to pick it up, so that we can say reliably we're going to get very similar kind of classification if we're looking at the same person.
Yeah.
The test-retest reliability was really done, we did the first classification and then within 2 weeks classified again.
Right.
Because we wanted to see whether the classification would be the same.
Yep.
And if you leave it too long in between, the kids can actually change.
Yes.
Yeah, okay.
Because they grow and things happen. So test-retest always kind of has to happen within a short period of time, but not within enough time so that the kids remember what they've done.
Yes.
So for all of the other kind of assessments, cognitive assessments and tests, if you do it again, they're kind of there's a part of recall for it, but this is not. It's just how they're moving. So it was a little bit easier.
So it was pretty good. We might as well just talk about the results from that one now. In terms of your reliability of using this particular classification tool, it's good, wasn't it? In terms of, can you describe, I guess, I don't know if you remember the numbers, but in terms of how we describe reliability, how good was it?
The test-retest was good. It just showed that the kids were classified the same way, and I think it was probably more than 80%
I
of
think you
those
had
that we actually retested.
100% agreement for your extension deformities and 80% for flexion.
Hey.
So, you're spot on.
Good.
The 100% for extension was a little bit trickier because there were a smaller proportion of kids with extension deformities.
That
but,
makes sense.
They're easier to see and distinguish between the 2 extension levels, whereas flexion's probably a little bit more, needs a little bit more thought.
Yeah. And did you find that where you did see differences between raters, were there kind of common sections of the classification tool where you saw those differences?
There were. So this goes to the inter-rater reliability.
Yes.
So test-retest was good and it was easy because I did it. Based on the population that we saw here in WA. This is from a national, the reason why the numbers were so large was because it's a national trial where we were able to kind of take a lot of data from. The inter-rater reliability, I think there were 10 different assessors that classified hand deformity. So for us,
which is so thorough.
It is.
Yeah, and 100 and something limbs. So that was
Jeepers.
That was to kind of go, well, if I assess, am I getting the same as somebody else?
Yeah. Yep.
So that it is, so that if we were to classify, not assess, sorry, if we were to classify, then I'm going to get the same classification level as somebody else.
Yeah.
And
for a bit of context, I think it was 70% agreement between raters for your flexion deformities and 92% for your extension.
Yeah. And the main difference with the flexion levels was the difference between F3. F3 was probably the more challenging level, and that's where we saw most of the difference. A couple of them where we went back and had a look at the kids, it was kind of no, they're definitely that classification, so it might have just been an anomaly.
Yeah.
But the F3 level is when you actually go to pick something up and you push down on the object and your wrist comes back, it's that passive force that's creating your wrist to extend. It's not an active extension.
Right.
So F1 and 2, you've got active wrist extension there. Whereas F3 is that it's passive extension. F4 is that even if you go to pick something up and you push down, your wrist stays in flexion.
Sure.
And
Okay.
F5, it just doesn't move and is flexed.
Yes.
So it's that difference between, yes, I'm classifying that as an F3, but somebody might have said, oh, no, I think that's an F4 or
Sure.
because the wrist was moving, it was more the difference between the F2 and F3.
Right.
And I feel like when you were describing that, I was also thinking about like GMFCS levels and how sometimes that 3 is kind of a bit of a transient classification that, you know, there's some elements of 2 and
That's so
sometimes there can be
true.
some elements of a 4 and, you know, it's kind of hard to pin down a 3.
Yeah.
So I think from a clinical perspective, you want to be as accurate as you can be.
Of course.
Yeah.
But because it's a classification and it's a guide, then you're actually going to put hands on and feel what's going on
And to
in the
assess.
muscles and you're going to assess. So it's not really, I wouldn't be kind of worrying about, oh my goodness me, I don't know whether it's this or this.
Yeah.
It makes sense.
Because it's going to become more evident
That's right.
the more you assess. From a research perspective, to get those numbers of reliability was really pleasing.
Oh, to say the least.
There would have been some celebrations, I have no doubt.
Yeah.
That is really cool.
Yeah. And just quickly to finish off with your results on your construct validity, because, you know, there was also a lot of work that went into that. We touched on the fact that you had 9 out of the 10 predicted correlations supported, and the one that kind of fell away and wasn't correlating as you thought it might with your classification system for body structure and function was age. Yeah. So why do you think that was the case?
I think that was the case because the hypothesis was that the older that you get, the worse your hand deformity gets.
Sure.
And I think proportionally from clinical practice, I think a third of the kids might change, a third sort of stay the same, and a third it's really variable.
Mm-hmm.
So it's not the whole population that's going to actually get a worse deformity. And, you know, we had kids that were 8 months old that had deformity. So because the kids already had the deformity and it was already present, it was really hard to kind of then go, oh, is it going to get worse? How is it going to progress? How do we measure it? So I just don't think that I had considered that when I developed that hypothesis.
Yeah. So how might we use the classification system for perhaps those younger children who haven't started to show those deformities yet?
I think now with early detection and with the hand assessment for infants, you're really seeing that difference in asymmetry and seeing how the kids are actually using their hands and whether there is something that's not quite right that you would expect from a developmental perspective as well. And I think some kids aren't going to have any hand deformity and some will.
Yeah.
It just is a tool to kind of go, oh, it doesn't look like it would normally look if I ask the kid to move or if I engage them in play, because you're not going to, you know, a little kid's not going to move the way you want them to move.
Very
but if
rarely.
you can use the objects to get them to initiate any kind of movement, you'll be able to see where there's an imbalance in the way that they're moving.
Yeah.
And does that mean that you have to do something with it? No, not at all.
Something you can just monitor.
But definitely something that you want to keep an eye on.
Yeah, sure. So just to sort of, I guess, move on from that point now, just to relate it with regards to the activity measures. So 2 out of the 7 were confirmed as part of your hypotheses. So that, I mean, did that surprise you? And what were your thoughts about why that was the case?
It didn't surprise me because the activity measures really, because the classification is impairment-based.
Yep.
The activity measures are normally how would you do an activity, how would you use 2 hands together, how do you normally handle your everyday objects.
Yeah.
And no matter your level of impairment, you can still score quite high on those, especially if it's just the one limb that you're looking at. So there's the difference between the unilateral impairment-based measure against a measure that's trying to look at two-handed use.
Yeah, yeah. I think it's sort of the way I kind of relate to it a little bit as well is, you might do some body structure and function impairment assessments, which are really important to understand what you're seeing. But it doesn't necessarily negate what they're able to do. And I think there's been a shift in sort of understanding that over time because, it's relatively, I guess, traditional, if that's the right word, when you kind of go, you'd assess the body structure and function. If they don't have a certain muscle strength, this was the one that, blew me away about 15 years ago. Someone only had a 2 out of 5 manual muscle test, yet they could still stand and walk. And you're like, what? And, there's elements about how the body does work and how you do have compensatory and just the, how you set up an activity to be done as well. So it does just kind of speak to that a bit. Like, is that how?
Yeah. I think we're really just trying to measure capacity.
Yeah.
With it.
Yep.
We're not measuring performance.
That's right. Yep.
And so we get an idea of what the best the child can do.
Yeah.
But when you actually then start to add cognitive demand and excitement and activity that they really like, that you get a really, really different picture.
Yeah, yep. And I think it's just really important to know that because, you don't want to limit someone from being able to do something because they haven't got their body structure and function measures the way you want them to be right there and then. You kind of go, well, that tells me something, tells me a picture, can help me guide those kind of interventions. Yeah. But it doesn't stop me from kind of going, the kid wants to do this. Let's find a way to make it work.
Yeah, they're always going to have some level of impairment.
That's right. Yes.
But it's not going to stop them from being able to do certain things or for you helping them to try and achieve what they want to do or to adapt the environment so that they've got some level of success.
I feel like you just described what our role as therapists are. Yeah. Right? Like that's pretty much it. I love it. Yeah. Just like that. Just
like that.
My job.
And I feel like that's been a common thread through our conversation. It's all about building the bigger picture and coming back to what's meaningful for the child and what they actually want to do and finding ways to support them to do that. So thank you so much, Simon, for sharing all of your wisdom with us today. I feel like we've learned a lot.
We have. But I love Simon.
Yeah. My final question for you is where to from here? You've spent a lot of time and effort building, this body of work. Where do you want it to go from here?
From here, I'd really like to look at the longitudinal change over the lifespan because I've had the joy of being working at the kids' hospital, but I've also worked with adults. So I've kind of seen that long-term picture of what can actually happen and it can be a bit scary and especially for the people very limiting and quite painful later on down the track. So looking at that longitudinal basis, but then also looking at how we intervene. I think it's important to know how your child is actually presenting to you from a biomechanical perspective so that then from a body structure function you can actually look at what they're doing from an intervention perspective, like using upper limb orthoses and splints, is that you really need to know what they do, why you're actually applying them. Yep. And then you also need to consider the context of the person and what they want to do and what experiences they've had before because I know that I've made made splints for people before and, they put them on and then 2 days later they're not wearing them anymore. And I think that's more just being really targeted of not explaining properly what it was for, picking the right activity for them to wear it if it was for during the day and really explaining what those long-term outcomes and effects were. So for me, it's kind of how do I draw all of those things together to help guide therapist decision-making when they're actually looking at that specific intervention. So those three main areas, what the splint does, the presentation of the child and the environment and the families and what they want to achieve with it.
Lots to keep you busy.
Just a little bit.
Just a little bit. I just love the reflective practice to that, Simon. I think it's Yeah, it's just wonderful that you're drawing on all those areas that you've worked in and really just put it into this context and just sharing it with others. So it's amazing.
Yeah.
So look, we're not quite done with the podcast yet, so I'm not going to say my complete thank yous because we're about to head into the next segment, which is called Tell It to Ed. Now, as you all may know, Ed is our producer, doesn't have a background in child health. This is a bit of a different one for him today, so we're really wanting to see what he's come up with today. No pressure or anything. So Simon, in about 60 seconds or so, can I get you to describe your research to someone who doesn't have a background in child health about what it is that you've done and some of the outcomes, and then in turn, Ed will have a question.
Yeah, so I looked at hand deformity and how people's muscles move their wrist and fingers and put them into weird shapes, because that can limit how they use them and it can cause pain later on down the track. And so it was really just to see if we could describe it. And then if we can describe that really well, then we can work out how we actually treat it.
Love it. That was great. Love it. Thank you, Simon. Ed. Hello, Ed. Sorry. Hi.
Hey, how you doing?
Good. All right. Well, over to you for a question.
So I've been learning quite a lot today. So I've not really thought about things like classification scales and all the work that kind of goes into that. So I'm kind of curious about the mechanics of classification scales and how they kind of get adopted and what the widespread adoption is for these kind of scales and what kind of benefit it would have for like a layperson or a parent of a child or a young person who has a disability, and what I can kind of take away from that. I don't quite understand how it gets from your research to a broader adoption.
Good question.
That is an excellent question. Thank you. It takes a really long time for things to be adopted because it takes a while to spread the word and get that knowledge out there. So from a professional perspective, we present at conferences and we do podcasts and try and teach those people that we're working with to use it as well, and hopefully it kind of spreads. So fingers crossed the use of the classification will kind of start to work its way out there. And I've presented at hand therapy conferences and the cerebral palsy conferences as well. So it's people have heard about it, whether they pick it up and adopt it, that's another thing as well. But from a family or an application from the family perspective is that if I can say, if you have a look at the way that your child's wrist and hand is moving and you see their wrist going into this position and it gets worse than that and they lose that ability to straighten out their fingers, then you need to talk to someone about doing something about it so that we can actually treat and manage it.
Yeah.
So it is, even though it's a tool to help guide therapists with their decision making, you can still incorporate it in those everyday conversations that you're having with the people that you're seeing, and match that with, if you're pushing your wrist and your fingers back, how much can you push them back? So that then you can see whether or not they're losing any muscle length, or if it's causing problems with, or when they move, they go into this funny position. It's just a way of opening that conversation with them to kind of go, yep, it might be, their muscle tone that's kind of driving them in that position, but then you can kind of look at the structures and see if there's anything that you can do to manage those individual structures to make it easier for them to do some of their activities.
That's a great answer.
It is.
Good question, Ed.
Yeah,
Thank
as
you.
always.
I have one really quick question.
Oh, she's really snuck in there. Okay.
No, time's up.
I'm curious.
Nice one, Simon.
I'm now curious about competing classification scales. Like, is there other work out there that's doing something very similar to the work that you did?
Not in this space. Not that I know of. There is a surgical classification that I talked about with the Zangoli classification, but that no, there isn't anything else that's kind of looking at classifying hand deformity that I know of.
They're not going to become over-classified.
I don't think so.
No.
No, I think that's a great opportunity to talk about how we can use classification tools for education pieces and a point of conversation with families. Like it kind of has to come down to that point as well, doesn't it? And like, why are we looking at this? And what's guiding our thinking is actually based on something.
And we don't see the kids every day.
That's right. Yeah.
But the parents do, and they notice change.
Yeah, absolutely.
Really quickly.
Yeah. Oh, well, we could talk to Simon forever. And when we did share an office together, I probably bugged him so much. Simon. It was brilliant. So, look, I could keep talking to you forever, like I said, but we do need to finish off the podcast. Thank you so much for coming in today, Simon.
Yeah.
Absolutely. Hand on my heart. Just absolutely loved that conversation, where it brought us, and just the pearls of wisdom that you just dropped every now and then. It was like here and there. It was wonderful. So, to all of our listeners, remember you can have links to the website that Simon was talking about as well as links to the paper on researchworks.net. And remember, there's also a CPD form there that you can fill out if you want to keep this as part of a record of your PD requirements. But for now, I guess we say thank you and goodbye.
Yeah. Thank you for coming to see us in person as well. I feel like we've spent so long in just our own company with people online over Zoom that it's nice to have
I feel a bit naughty being in
a fourth face in the studio.
in the same room as other people.
I know. It's a different feeling, isn't it? Don't worry, we all ratted beforehand.
We did
ratted beforehand.
Back to the rats.
And, mutually beneficial relationship in the office.
That's true. That's right.
I learned a lot from Dana as well.
Thank you very much. Well, we'll have a chat to all of you guys again next week.
Yeah.
Bye.
Thanks, guys.
Bye.